much for having me today. I'm so excited to be here on World Diabetes Day to celebrate and talk with you all for a little bit. So let's go here. So today, so like you said, I am a pediatric endocrinologist at the University of Florida. I've done all of my training at UF, so go Gators. But I am originally from Titusville, so just a little bit away from here. Got to go visit my family this weekend, so that was really nice. But today what I'm going to be talking to you all about is understanding recent advances, challenges, and opportunities in pediatric diabetes care, and particularly in prevention, so pediatric diabetes prevention, technologies, and quality of life. And I hope today on World Diabetes Day to inspire community advocacy and support for children with diabetes. And it's really near and dear to my heart because I am primarily, I take care of children with diabetes and also do diabetes research. And so this is something that's really important to me, and I hope to you all as well. So before we talk about prevention of diabetes in children, we need to understand exactly how big the problem is and where the problem is. So as you can see from this chart, basically what this is doing is breaking out age groups and the prevalence of diabetes, type 1 diabetes in particular, in different ages and by different demographic factors. And the blue dots are from 2001 and the orange dots are from 2017. So this is looking at the prevalence of diabetes in children over time. So as you can see, the blue dots are typically closer to the left and the orange dots are closer to the right, showing that the prevalence of diabetes in children, unfortunately, is increasing over time. And it's increasing pretty substantially. So in especially the adolescent age group, so 10 to 19-year-olds, you can see that the diabetes prevalence is pretty rapidly increasing over time. So type 1 diabetes comprises 75% of pediatric diabetes and has increased 45% in the last 15 years. So it's increased quite substantially, and we're not sure of all the factors that are driving this increase in type 1 diabetes, but it is going up. Type 2 diabetes is a lower percent of pediatric diabetes, but still substantial, and it's increasing even more rapidly. So more than 95% increase over the last 15 years in pediatric type 2 diabetes.
Since we're so intimate, can we ask questions a little bit as we go?
Sure, sure.
So why the type 1 increase do you feel? Do you have any kind of...
So there's a lot of different theories about why type 1 prevalence is increasing. It is more related to increased incidence. So when you say increased prevalence, sometimes people say, well, are they living longer? Are they, not like dying as much? And that's why the prevalence is going up. But really, that hasn't been an issue in the last 15 years. So it really is new cases of type 1 that are going up. As to why that's happening, there are many theories, whether it's there's the hygiene hypothesis that with the cleaner world we're affecting our immune systems. There's hypotheses about our diets and how they've changed over time. There's all sorts of hypotheses, infections, and what types of infections we're getting, our microbiome. So I can list a bunch of theories for you, but overall, I would say we don't know exactly why it's going up so substantially.
My apologies.
Oh, no
I
problem.
am handicapped at the elevators.
Oh, that's awful. Well, thank you so much for making your way up here. I appreciate it.
I'll make it my way.
Yeah. So other diabetes, so people don't know that there are other types of diabetes a lot of times. So there are actually genetic forms of diabetes called MODY. And then there's other forms of diabetes that are actually caused by problems with the other part of the pancreas that controls digestion, and those can spill over and cause diabetes as well. And so those make up about 3% of pediatric diabetes. So when you're thinking about diabetes, you have to keep in mind that there are a lot of different types of diabetes. Those rates, or it's published. I did not publish it, but it was published by in JAMA in 2021. The reference is at the bottom. Yep. Okay, so also, so basically to better understand what these different type 1 and type 2 diabetes. So in a normally functioning body with a normally functioning pancreas, insulin is a key hormone that travels throughout the bloodstream but is made in the pancreas, and it lets our bodies use glucose as fuel. So it goes to your muscles, it goes to your fat, it goes to different parts of the body, and basically allows glucose to be taken up into those parts of the body and used. In type 1 diabetes, the cells that make insulin are called beta cells, and they're located in islets. So you'll hear, islet autoimmunity basically means that it's autoimmunity against the cells that make insulin, which are the beta cells within islets. And the body basically attacks those cells, so it gets confused, and we're still figuring out the reason why it gets confused, but the body gets confused, and the immune system attacks the beta cells that make insulin and kills them off, and so then we don't make any insulin. And so you have glucose floating around when you eat a meal. So if you eat a meal that has carbohydrates in it, those get broken down into glucose, and then the glucose goes into the bloodstream. And then once the glucose is in the bloodstream, you need insulin to tell the rest of your body to use the glucose. But you're not making insulin anymore in type 1 diabetes. And so glucose floats around, you basically can't use it, and so you end up urinating a lot of it out. And so that's kind of those classic symptoms that we think about with diabetes, where you urinate a lot, you're really thirsty all the time, is because you are urinating out all the extra glucose that you can't use. And then when you can't use glucose, your body has to use something as fuel, and so it breaks down fat. And a byproduct of breaking down fat is ketones. So that's kind of one of the principles behind the ketogenic diet, is breaking down fat, and you kind of measure your ketones over time to see how your diet's going. But in type 1 diabetes, breaking this down is actually very dangerous, because in the ketogenic diet, these people are still making some insulin, so they're still able to use some glucose as fuel. But in type 1 diabetes, they're really not making much insulin at all, and so you get dangerously high levels of ketones in the body, and that can cause, they're acidic, and so it basically causes the blood to be acidic, and that's not good for you at all. And so the only real treatment for type 1 diabetes is insulin, because that's what you're missing. And so these people need constant access to insulin. In type 2 diabetes, what starts everything off is that your body can't use insulin as well. So it's a little bit different in that you're still making enough insulin, and even at one point in the progression to type 2 diabetes, you make more insulin than usual. But your body is not efficient at using it. And some of this is caused by excess fat, and especially fat in the liver, we found is a really predisposing factor to getting type 2 diabetes, and it prevents your body from being able to use insulin as well. And so insulin is floating around, but you can't use it, and so you get some of those same symptoms because you still can't use glucose. And so you pee a lot, you drink a lot, you can end up making ketones actually, but that can be really farther down the road. And eventually, because your beta cells are working so hard to make enough insulin, they're like, okay, we're trying here, we're trying to keep up, and so they make a ton of insulin, but they burn out over time. And so eventually, your beta cells are lost because they are working so hard that they eventually die. And then it's similar to type 1 diabetes in that you now no longer have enough beta cells as well. So going back to type 1 diabetes, as I mentioned, it's an autoimmune disorder, and it affects 1 in 300 children and adolescents, and so it's pretty common. These adolescents are typically, the peak incidence is in 10 to 14-year-olds, so that's when you get the highest number of people diagnosed, but it can happen as young as an infant. And it's really worrisome when an infant gets it because we miss it a lot of times because we're not thinking about diabetes in a baby. And so they can get really sick before we figure out what's going on. But babies can get it all the way through adults. So that's another thing that people don't know, is that actually the most type 1 diabetes is diagnosed in adults. And so because people always associate adults with getting type 2 diabetes, we miss a lot of adult cases of type 1 diabetes as well, just because we're not looking for it and not thinking about it. But it does happen frequently in adults. Basically, it's a complex interaction of the immune system, attacking the beta cells when they're not supposed to, but we're still figuring out exactly why this is happening. So people have genetic predispositions, so there's a group of genes called the HLA genes, and those control your immune system, basically. And people with certain HLA genes are a lot higher risk of getting type 1 diabetes. So we know it has something to do with your immune system. There's also race and ethnicity play a factor, so people who are white or people who are black are the most likely to get type 1 diabetes more than other races and ethnicities. Family history does play a role, so if you have a family history of type 1 diabetes, you're more likely to get it. But most people who have type 1 diabetes don't have anyone in their family who has it. So the majority actually don't have a family history, but it does make you higher risk if you have someone. And then geography, interestingly enough. So people who live away from the equator, in Scandinavia actually is the highest risk of type 1 diabetes. So there's something about where you live that actually makes you more likely to get type 1 diabetes. And there's all sorts of theories about that, whether it's their genes, that make it more likely, or the fact that it's cold and they're indoors a lot, and so they get more viruses is another theory for why they could potentially get more type 1 diabetes. But we don't really know for sure. But it's interesting, it does kind of run along the equator. And so if you live in northern climates, you're more likely to get it. Other factors, so basically, as I mentioned, there's a genetic risk for type 1 diabetes. And then we think something happens to you to make your immune system react against the beta cells. And we've done all these studies over the decades to try to figure out what that something is that happens to people. But unfortunately, all those studies have shown us that it's more than one thing. So there's not one virus or one thing that you're missing or one diet change that gives everybody type 1 diabetes. It's a bunch of different things kind of come together. So there was a study that we looked at kids from birth, basically, and followed them really closely, like every month at first, and then every 3 months, to try to figure out, did they get a virus, and then they got type 1 diabetes? Did they, breastfeed or formula feed, and that's why they got type 1 diabetes? So we really tried to figure it out, and what that study showed us is there are multiple factors, and each person is going to be a little bit different. So there are some viruses that were linked to development of type 1 diabetes, so we think that maybe viruses do still play a role. We're also looking at the role of the microbiome, so the bacteria that are in your gut, interestingly, may play a role in development of type 1 diabetes. And then we're still looking at different dietary factors, but I can tell you for sure it's not just one dietary factor that plays a role in type 1 diabetes. So we're still looking at vitamin D and probiotics and those sorts of things in young children to see if that can make any sort of difference, but it's not just them. And so all these things kind of come together, unfortunately, and cause the immune system to attack and destroy the cells that make insulin. So when we're talking about prevention, that is really what we're working with to try to figure out how to prevent type 1 diabetes. And so we start with genetic risk. So we're able to look at babies and children who have higher genetic risk to study them and see, if they develop type 1 diabetes. And then at some point you have the start of an autoimmune response. And so the first signal of that is something called antibodies. And it's great that we can figure this out because now we can actually see, even years before somebody gets type 1 diabetes, that they are at high risk of getting type 1 diabetes by looking at antibodies which are in the blood. And so you can just do a simple blood draw and look for islet antibodies. So it's basically a sign that the immune system is attacking the islets. And once you get 2 of those antibodies, there's 5 total, but once you have 2 present in the bloodstream, you're at a very high risk of getting type 1 diabetes within the next 10 years. And so those are the people that we're really focusing on to try to see if we can prevent progression to type 1 diabetes. So we follow those people, and then eventually, over the years, so like I said, it can be years, even before, so you measure the antibodies that are there, and it can be years until they actually develop type 1 diabetes. But at some point, your beta cells start dying off and you get what's called dysglycemia, and so that's called stage 2. So stage 1 type 1 diabetes is when you have those antibodies. Stage 2 is when you start to get some blood sugar changes, but not enough to actually be called diabetes. You can just kind of see that the beta cells aren't quite keeping up like they should. And then stage 3 diabetes is what we clinically call type 1 diabetes. So when people say type 1 diabetes, that's what they're thinking of. So you have abnormal blood sugars, and you have to take insulin for those. And so in all of these stages, we're trying to prevent diabetes from happening. And so there are trials happening in every single stage of type 1 diabetes, from primary prevention in people who are just genetically at risk, to secondary prevention in people who have started to develop an immune response against the beta cells but don't have diabetes yet. And then tertiary prevention is once you have clinical diabetes, you can intervene to preserve what beta cells you have left. And so those are the 3 kind of stages of prevention that we're trying to do. So to do that, we have to focus on 3 different factors. So we have to halt the immune process that's happening against the beta cells. So we need to stop the immune system from attacking those beta cells. We have to protect what beta cell mass is there. So we need to make sure that those beta cells stay functional and they are continuing to work. And then if you have established disease, we're studying how to give you new beta cells. And so if you've lost your beta cells, what can we do to either regenerate them or implant them or give you beta cells back? So we've actually made a lot of progress. So it can be frustrating because the progress that we've made seems really slow to us because we want to cure diabetes, we want it to happen now. But if you look back, we actually have made, a fair amount of progress. So this is just kind of to highlight what we have done. So, 30 years ago was the first time that we ever tried to infuse some islet cells into someone to see what happened. Like, would it actually affect their blood sugar if we gave them some cells just through a peripheral vein? I don't know. And so we did that, and we showed that it did actually help for a while, and then, obviously it doesn't last. And so now researchers are looking at how to protect beta cells. So they're using different types of, this is where biomedical engineers really come in, because they're using different types of plastics, they're using different materials and methods to try to protect the beta cells. If you take a beta cell, you implant it into someone, you need to protect it from the immune system. And so people are working on how to do that. And there has been some, temporary success. Unfortunately, we haven't gotten to the point where it can last for years and years and years in doing that. So that's what people are working on. In terms of biology, so we used to think that once you got type 1 diabetes, all of your beta cells were gone. Oh well, they're gone. We don't have any more. But now, from some of the studies we've been doing, even at the University of Florida, we look at the pancreas of people who have gotten type 1 diabetes. And we were so surprised to see that there's actually insulin-producing cells there years after diagnosis. So we call them type 1 diabetes medalists. So it's people who've had type 1 diabetes for 50 years. And even those people sometimes will have insulin-producing cells in their pancreas. And so that gives us some hope that, since we do have some beta cells there, that maybe we can regenerate them, we can, get those to grow, basically kind of looking to see how we can preserve and increase those functioning beta cells. So Cpeptide is one way to measure in the bloodstream. So basically when you make insulin, you also make this byproduct called Cpeptide, and that is not in an insulin shot, so we know that it's coming from your own body. And so that's one way we can measure how many, what beta cells are left. And then the way that we really looked, for these studies, is we actually looked at organ donors who had type 1 diabetes and looked in their pancreas to see if they had insulin-making cells. So we made a lot of strides through that. And then 30 years ago, which is crazy to me because I use this every day, but we had no way to detect if somebody was at risk for type 1 diabetes. So we just knew they got it, but we didn't know how to figure out if they were going to get it. And today, we have these islet autoantibodies, which are excellent markers of risk for type 1 diabetes. And this is really how we're able to do all of our prevention trials, is measuring these markers in the blood and saying, within 10 years, you're likely to get type 1 diabetes, and so we're gonna try to do these interventions to prevent you from getting it. And so now we have these markers, and that's where a lot of our research has stemmed from being able to see that. So what are we doing now to try to prevent type 1 diabetes? So there was an excellent trial that was run by the Type 1 Diabetes Trial Net Consortium, which is a huge group across the country, basically that measures antibodies in the blood of family members of people with type 1 diabetes to try to find people to help prevent type 1 diabetes. And so they ran a trial using an immune therapy called teplizumab that basically is an anti-T cell therapy. So T cells are what we think is the main immune cell to really cause all this havoc on the beta cells. And so we want to try to kind of calm those T cells down and increase what's called regulatory T cells. So there's good T cells that kind of regulate the immune system, and then there's T cells that attack, which is good for infections, but not so much in autoimmunity. And so basically teplizumab helps to downregulate those immune cells that are attacking the beta cells. And the teplizumab trial was run in youth with stage 2 type 1 diabetes, youth and adults with stage 2 type 1 diabetes. And we were actually able to prevent diabetes for 2 years. So people who were at risk for type 1 diabetes, we were able to keep them off of insulin for an extra 2 years beyond what they would have been able to do on their own. And so that may not sound like a lot to people who aren't on insulin, but for people who are on insulin, I think a lot of them would give a lot to be able to avoid the use of insulin for 2 years and really give kids peace of mind. Some of these kids, we were able to avoid that period of type 1 diabetes in adolescence where it's just like really difficult to manage. And so pushing that out 2 years can really make a huge difference for people in general. However, we are ultimately wanting a cure, right? And people have been wanting a cure for decades and saying a cure is coming for decades. And so what is preventing us from getting a cure right now? So one thing is that we've discovered that type 1 diabetes is not one thing. And so it's what we call a heterogeneous disease, where everybody's a little bit different who gets type 1 diabetes. So that's what we discovered with the TED study, is that everyone has a little bit different risk, everyone has a little bit of a different trigger that kind of trigger the onset of type 1 diabetes, and there's not one trigger and one risk. And so it's gonna take individualized medicine basically to really get to a cure. And so we need to find the right patient to get the right therapy at the right time. And so that's gonna take a lot of personalized medicine to figure out which immune therapy or which other therapy is good for this particular patient at this time, and when should we intervene. And so that's one thing that we definitely need to figure out, and that's precision medicine, basically. Another thing that's prevented us from getting to where we want to be is that we've actually cured type 1 diabetes in mice 500 different ways already. So literally 500 different ways. One of my mentors compiled all the different trials where we cured type 1 diabetes in a mouse, and it was more than 500. So obviously our animal models are not perfect or even close to where we want them to be to actually modeling type 1 diabetes in a human. We fixed diabetes in mice, but we have to figure out people. And so because we did all of this work in mice, some of that has been a setback in thinking that these things are going to work in people as well. The other thing is we need to understand more what the mechanism is for type 1 diabetes, what triggers it, what is happening. And there's even some work showing that maybe there's an inherent problem with the beta cells, and that's why the immune system starts to attack them. And so it's a theory. Obviously, it's people are researching it and figuring it out, but we need to understand, and it might be different in different people for what triggers it, but we need to better understand what's causing type 1 diabetes. And then we are, making some great strides with immune interventions, but the strides we're making are transient successes. And so we can prevent people from getting type 1 diabetes for 2 years, but it doesn't last forever. And so that's another limitation that we have right now in curing type 1 diabetes, is figuring out how to make it, make them not get diabetes for forever, rather than just preventing it for a short period of time. And so some of that, we're starting to do trials with repeat immune therapies. They're just beginning. So there's one trial happening that is actually giving teplizumab twice. So you get it once, and then at a certain time later you give it again. And And so that might be one of the keys to helping to prevent type 1 diabetes. Another thing, study that we're doing at the University of Florida is both addressing the pathophysiology of type 1 diabetes, so how exactly is it happening, and also addressing getting more biomarkers to figure out who we should be treating and when. And that study is basically looking at the exocrine pancreas in type 1 diabetes, which has been ignored for many years, and now we're finally kind of addressing it. So basically, the beta cells in the pancreas only make up about 3 to 5% of the total cells that are in the pancreas. The rest of the pancreas is devoted to digestion. And interestingly enough, we found, our group at the University of Florida found that the pancreas is actually 30 to 60% smaller in people with type 1 diabetes, even though those beta cells only make up 3 to 5%. So where are the rest of these cells going? Why are they affected? Is what we're basically trying to figure out. Whether it's an autoimmune process affecting them as well, or the lack of insulin. There's a lot of different theories, but we're figuring that out. And we're also trying to figure out when, in the course of risk for getting type 1 diabetes, these cells are being lost. So when is your pancreas getting smaller? Is it something you're born with? Because maybe that would point to an inherent defect in your pancreas, or is it something that develops when autoimmunity starts? So would that point to it actually being an autoimmune process against the other part of the pancreas? Or is it just like right when you get diabetes because you don't have enough insulin? And so we're figuring that out by doing MRIs in people who are at risk for type 1 diabetes. And so we are getting family members of people with type 1 diabetes and people who have antibodies, those islet antibodies that they don't yet have full type 1 diabetes. And we're doing an MRI of their pancreas to see how big it is. And then we're also doing markers of exocrine function. So we're getting blood and other samples to do markers of exocrine function. And it's a one-year trial, and hopefully after that trial, we'll understand more about whether even pancreas size can be another biomarker, kind of in our tool for figuring out who we need to treat when, and then also understanding more about the pathophysiology of type 1 diabetes. Another really exciting trial that's upcoming in the next few months, hopefully, is the ATG prevention trial. And so ATG is a drug that Dr. Haller at the University of Florida really pioneered for treating new onset patients with type 1 diabetes, and now we're moving it to the prevention space. And so it showed, this graph basically shows that ATG helps to improve hemoglobin A1C in newly diagnosed patients with type 1 diabetes, and also helps, the top graph is Cpeptide, so that's that marker of beta cell function, and it helps to preserve beta cell function in people with new onset type 1 diabetes. And so we're hoping that by giving it even earlier, so people who are kind of on the verge of getting type 1 diabetes but not quite there, that we can even prevent or delay the onset of type 1 diabetes. So that's another trial that we'll be doing in the next few months is when it should be starting. All right, so moving on a little bit to type 2 diabetes in children. And so type 2 diabetes in children, as I mentioned at the beginning of the talk, unfortunately is rapidly increasing. And so it's gone up 95% in the last 15 years. So a lot more kids getting it. It's about 1 in 1,500 kids. So it's still more rare than type 1 diabetes. So type 1 is more like 1 in 300, whereas this is 1 in 1,500, but becoming more common. And it's most commonly diagnosed in the older adolescent age group, so 15 to 19. And so how this happens is another giant area of research, and we know it starts with genetics. And so people who get type 2 diabetes are just more prone to being insulin resistant. And so their bodies just don't utilize insulin in the same way as people who don't get type 2 diabetes. And so they start out with a risk in terms of being prone to developing insulin resistance. And there are certain populations that have higher rates of type 2 diabetes. And those include people from the Pacific Islands and people who are Native American, and people who are Black have the highest risk of type 2 diabetes. And those are the populations that we're really trying to study some of the factors that lead to type 2 diabetes. People with type 2 diabetes also have an even stronger family history of diabetes than type 1 diabetes. So everyone thinks of type 1 diabetes as being like the genetic risk sort of diabetes, But actually, type 2 diabetes will run much stronger in families than type 1 will. So after you have this genetic risk, then the environment comes in. And so, as you know, our entire society has become, we don't eat as healthy of foods. And so some of the things that we eat that are higher in carbohydrates and fat, and just some of the more unhealthy foods can lead to buildup of fat in the liver. And that's the most important fat for the development of type 2 diabetes, is that intrahepatic fat. And then exercise is another important factor for helping to prevent type 2 diabetes. So exercise actually helps reduce the fat in the liver, even without weight loss. So that's really an important point. Even if you don't lose any weight from exercise, it's so important to do it because it's reducing that really risky fat that's in the liver. So exercise plays a role. And then of course, just society. So there's studies showing that toxic stress and adverse childhood experiences can increase your risk for type 2 diabetes. So some of this, like high cortisol levels and stress, increases your risk. Lack of access to healthy foods, lack of access to play areas, in schools we're so focused on tests now that we're cutting out PE and recess, and just all these sort of factors kind of come together to cause risk for type 2 diabetes in kids. And so in type 2 diabetes, I mentioned at the beginning, it's a little different, where you initially actually have more insulin coming out, so your beta cells are working in overdrive at the beginning to try to keep up with the demand for insulin, and then eventually they burn off and kind of die off because of how hard they're working, basically. And so eventually your beta cells do die off as well, and then at that point your diabetes kind of more closely resembles type 1 diabetes, because at that point you have a relative insulin deficiency as well. So what strides have we made in the prevention space in kids for type 2 diabetes? A lot of it, I feel like we learned what does not work. And so we do know that temporary dieting and sort of these fad diets in kids do not work. So don't do them, don't put your kid on a soup diet. Unfortunately, the fad diets are not working. So they're actually associated with paradoxical weight gain. So you think you're doing good by your kids, but you're actually paradoxically causing weight gain, and they can cause binge eating disorders. And so we want to avoid just the fad dieting. Another thing that we've actually found out is not good for you is weight cycling. And so that's when you lose a bunch of weight, and then, because you're doing a fad diet or whatever, and then you regain all of the weight, and you actually end up gaining more weight back than you lost. And we've discovered that this sort of weight cycling, so going up and down and up and down and up and down, causes increased risk for insulin resistance and inflammatory markers in kids. So that's what it's really been linked to in kids. And then in adults, it can cause increased risk for cardiovascular disease, renal disease, and mortality. So nothing that's good. Another thing that we've discovered that doesn't work is weight stigma. So a lot of campaigns, back 10, 20 years ago would try to sort of shame people into losing weight by making them feel guilty about it, or these campaigns, saying that kids need to avoid the phase lines. There's all sorts of terrible things that you can look at that we did in the past with public health campaigns. Actually increases, like I mentioned with the fad dieting, these shaming campaigns actually increase weight gain. So rather than reducing weight, kids will tend to gain more weight when exposed to these campaigns. It causes unhealthy eating behaviors, emotional and psychological effects. And then kids who are overweight can actually, from feeling all this shame, can avoid exercise. So they're ashamed to exercise in front of other people. And so it actually causes them to not exercise, which is the opposite of what we want them to do. And so all these sort of shaming campaigns have really been shown to not work and be detrimental to kids. Low self-esteem, depression, decreased quality of life, healthcare avoidance. So it's actually been shown that overweight and obese, or girls with overweight and obesity in adolescents don't get their HPV vaccines as much as girls who are not overweight or obese. And so we think that's from healthcare avoidance and just not wanting to see doctors because they don't want to hear the shaming over and over. And so we're really retraining ourselves on how to talk to people with these sorts of issues. So what can we do? So if shaming doesn't work, what is there to do? And if these weight cycling and fad diets aren't working, then what should we do? So one thing we can do, it has been proven that increasing the quality of kids' diets really does make a difference in their health. And so unfortunately, kids have the highest intake of empty calories of any group in the United States. So that's so sad to me as a pediatrician. People may think it's harmless because at this point in their life, they are not overweight. 1 to 3 year old isn't going to usually be obese. It takes some time. But you're introducing habits and behaviors, even in the 1 to 3 year old age group. And so we really need to work on increasing the quality of our diets in these young children. And as I mentioned, I actually don't think I mentioned this, but once you gain weight, it's a lot harder to lose the weight than just preventing the weight gain in the first place. And so trying to introduce healthy habits in kids and healthy diets and avoiding empty calories is one way to go. So this graph kind of shows where our diets as Americans should be versus where they're actually at. And so the orange is more of a deficiency, and well, I guess it's a deficiency on the left and it's an excess on the right. And so Americans' diets are very lacking in vegetables. So when your mom says eat your vegetables, it's actually very important that we increase kids' vegetable intake. This is my general pediatrician coming out. I don't have to say this as much anymore, but some kids have to try something 10 times before they like it, literally 10 times. So you have to give it to them, just put it on their plate, and they need to put it in their mouth 10 times before they'll even kind of tolerate it. And so it takes some time, but it is important to eat more vegetables. We also need more fruit, whole grains, dairy, interestingly, which I wouldn't have thought, but non-fat, low-fat dairy. And then less added sugars. So I've actually taken to looking at the added sugars in all my kids' food. I have a 2-year-old, and you would be shocked at some of the added sugars that are put into kids' foods that you just wouldn't even think. And then less refined grains, less saturated fats, and less sodium. So other things that we can do is improve the cardiovascular fitness of kids. As I was mentioning, a lot of schools unfortunately cut out PE and recess, but it really is exercise, even without weight loss, really prevents cardiovascular disease and diabetes. And so fitness is very important. So there was one study showing that they basically did a fitness test at age 18, and it predicted the development of diabetes in adulthood, and kids at 18 who weren't fit had a 3 times higher risk of developing type 2 in adulthood. And unfortunately, over time, children's cardiovascular fitness has fallen quite substantially. And kids today run a mile about 1.5 minutes slower than they did in 1970. So we've really got to work on our kids' fitness. So how can we do all of this? So one thing we can address is the quality of kids' food. And so kids actually today, you might be surprised to know, are consuming their highest quality food at school. So everyone thinks the school food is terrible, but there was Obama-era legislation that was passed to improve the quality of kids' food in school, and that actually did make a difference. So it went from the kind of poor category food to the intermediate category, which is actually pretty good for us. So kids' food in school is actually, when it's studied, that's where they're getting their healthiest food. The unhealthiest food is coming from restaurants, and that does include fast food restaurants. And so we really need to figure out a way to improve the quality of food in restaurants, or just eating less at restaurants. So one of those things. But it's mostly coming from a lack of fruits and vegetables, and too much saturated fat and sodium, which isn't surprising. One thing that I was happy to learn is that we've had a campaign to reduce soda intake and juice intake over the last 10 years, so we've really pushed this. And we've actually cut soda and juice intake by half through all of our public health campaigns and efforts. So that is becoming less of an issue, but some of the more processed foods and saturated fats and sodiums are becoming more of an issue over time. So it's always something to address, and that's something that we need to address. So what about medications? So the RISE study was conducted in pediatric patients who were either had pre-diabetes or were at early stages of type 2 diabetes. And we're basically trying to preserve beta cell function in these kids. Because as I mentioned, after a long period of insulin resistance, you actually start to have your beta cells die off. So we were trying to see what can we do medication-wise to preserve these beta cells. And one unfortunate finding that they discovered was that kids with type 2 diabetes lose their beta cells a lot quicker than adults. And so that really period of preservation of beta cells needs to happen pretty early on because they do lose the function pretty quickly. One thing they did find is that kids were basically randomized to start insulin or to start a combination of insulin and then metformin. And kids who were on the medications did preserve their beta cell function longer than the kids who were not on medication. But then once they stopped those medications, the beta cell function declined after that. So it was really needed to be continued long term, unfortunately. And so what all of this taught us is that we really need to figure out, like I said, prevention is key. So not developing any of this in the first place would be ideal. But once they do develop it, we need to figure out ways to preserve beta cell function longer. And then, where am I at time?
You're okay, because not everybody else is still back in, so I can keep going over. You're okay.
Okay, yeah, sure. Let me know when I'm short on time. So in the tech space, you have a whole talk on tech, so I'm not going to cover it in great detail, but there has been a lot of advancement in tech recently. And so this is just showing the first insulin pump. I don't know in the first talk if they showed that, but it's so cool to me that that was our first insulin pump. So we've come a long way. And then I don't know if anybody in this auditorium remembers when you had to check your glucose with urine strips, but there was basically these urine strips that would either show you if you're high or not, and that was that. And so we've come a long way in terms of being able to measure blood sugars. And so now, this is all the tech that we've got to help kids to maintain normal blood sugars. And so I'm assuming you got a lot of talk about continuous glucose monitors and how excellent they are, and insulin pumps. So we have our first artificial pancreas systems that have come out. They're not fully artificial pancreases to me because they don't bolus for food yet. You still have to announce your food, but other than that, they really help with blood sugar fluctuations and have improved A1Cs and time in range quite a bit. However, with all of this tech, I don't know how many of you have seen this graph. It's just so discouraging to me, but this is how our A1C has done. So basically, it was a period of around 11 to 12 is in the red, and this is a graph of hemoglobin A1C by age. So as you can see, there's a nice jump in the adolescent age group, because that is really the hardest time to control blood sugars is in adolescence, and then it kind of goes down. But blue is 2016 to 2018, and so we've actually gotten worse from that, the earlier time period until now. And so that's with increased tech adoption. So the graph on the right is showing how many kids are on CGMs and pumps now. And so despite more kids being on tech, we have a higher A1C over time. And then these graphs are a little bit more confusing to read, but basically it's showing how much disparity and inequity we have in our tech use. And so the very left is the DPV, which is basically a giant consortium of people with type 1 diabetes in Europe. And it's showing you how hemoglobin A1C looks across the 5 different income levels. So they had 5 income quintiles, and how tech is distributed among the 5 income quintiles. And so if you can see, those graphs on the left are pretty flat, like straight from the first quintile to the last quintile. People are getting access to these things, and their A1Cs similar at least. And then for us, the T1D exchange is our giant type 1 diabetes consortium, and this is showing you quintile 1 to quintile 5 and how much disparity there is in tech use and in hemoglobin A1C. And unfortunately, it's showing that the disparity over time has increased. And so that's also kind of reflected in the graph on the right. The lower part is hemoglobin A1C and how much it's reduced by having a higher income. So in DPV is the yellow bars. So DPV in Europe, your A1C is better if you have a higher income, so it's lower, but the blue bars are us, and that's how much better your A1C is if you're in high income groups. And then the top part is tech use. So DPV honestly doesn't have a ton of advantage in tech use by having a lower high A1C, or sorry, lower high income quintile, but we are the blue, and so we have a lot more people on tech who have higher income. So where can we go from here? So one thing that's being done is the NIH is actually now funding trials to improve equity in technology use. And so they are interested, and sometimes it's hard to get funding for research on improving health disparities, but the NIH has really taken a great interest in this and is kind of funding some of these trials. And then you've all probably heard all about the new tech coming out, but there are smaller CGMs coming out. There's inhaled insulin that we're doing a trial of at UF. There's all sorts of new tech. There's some pumps that use not only insulin, but glucagon and amylin as well, which are other hormones missing in type 1. So lots of exciting technology happening. And then real quick, just to hit on quality of life. So what can we do to improve quality of life for people with diabetes? And so some of it, tech really does help quality of life. So we've made some great strides. If anyone's on an artificial pancreas at nighttime, it's just so much better. Like, you're just so much more reassured that your kid's going to be okay with their blood sugars overnight on these artificial pancreas systems. So it has improved quality of life pretty substantially. There have been more recent campaigns about diabetes awareness. And so hopefully these campaigns are reducing stigma and increasing support and advocacy for people with diabetes. So November is Diabetes Awareness Month is one example of that. However, people with diabetes are still experiencing a lot of stigma. And so this is a list of kind of points that people brought up in a survey by Diatribe about what people experience who have diabetes in terms of stigma. So some of the things that they wish. One thing that always hits me is people commenting when people inject insulin outside of the house. Like, it was Sonia Sotomayor, so she has type 1 diabetes, and somebody saw her injecting insulin one time, and they basically told her she should stop doing drugs. Like, they thought she was doing injectable drugs. And someone commented to her about that. And so just, the stigma about taking care of your diabetes, it's a 24/7 disease. So you have to be able to inject insulin, check your blood sugars. I've had parents, of newly diagnosed people, so they don't know any better yet, but saying like, oh, I'll never help her check her blood sugar, that's gross. Like, what do you, I'm not gonna do that, it's gross. And I'm like, well, you're saying this in front of your kid, is gonna have to check their blood sugar, many times in their future life, and saying it's gross is not helpful. So things like that. That people didn't equate diabetes with being fat or lazy, so I hope that I communicated that even type 2 diabetes is a very complex process, and it does not help anyone at all to associate it with these horrible stereotypes. And then what are some other good ones on here? People know I didn't ask for this disease, and then people know how much it costs. So I have time to talk a little bit about cost. Here it is. So basically, for kids living with diabetes, the cost of a pediatric patient is over $7,000 a year, and the out-of-pocket cost is over $2,000 a year for the parents of kids who have type 1 diabetes. And this cost is 5 times that more than those without diabetes. A lot of patients have reported, more than a quarter have reported rationing their medications because of cost. And almost a quarter have reported that cost is actually their most significant barrier to diabetes management. So people with diabetes already have a hard enough time, like it's a 24/7 disease, there's so much stress, like they shouldn't have to be worrying about cost in addition to all these things. And so this is a picture of Hunter, and he actually was rationing, so he is a spokesperson for the ADA, and we're on an advocacy committee together, but he went to college, and his basically out-of-pocket copay for his insulin was insane, so hundreds of dollars. He didn't want to bother his parents about it, and so he ended up rationing insulin at school, and was very ill and had lost a bunch of weight because of rationing insulin at school. So it's a huge problem. Other things, so in order to avoid stigma, one thing that we can do is use people first language. So instead of saying a diabetic person, say a person with diabetes, and it just kind of helps emphasize that these people are people first instead of putting their illness first. Another thing, just think before you speak. In general, is good advice for everyone about everything, but so people with diabetes have to deal with a lot of unprompted advice about their disease, and I call it advice. I don't know if it's really advice, but it's really not helpful if it's unprompted advice about what people can eat. So my poor friend Chelsea, who has type 1 diabetes, has to deal with this all the time. Like, she'll eat a cupcake and bolus for it, do everything right, and like people are like, oh, you're eating a cupcake. You know? So yes, people with diabetes can eat dessert, and it's okay. She also gets unprompted advice about cures for diabetes, so like supplements and all sorts of things that people just come up to her and tell her, well, how do you try this? And just like, if I could cure my diabetes, I would do it. And then how to live their life. So just, generally unprompted advice is not helpful. Diabetes management is 24/7, so like I said, we should let people with diabetes manage their disease in public without having any issues or staring or rude comments. And then not blaming people for a really complex multifactorial disease. So instead of blaming people, really trying to work with people to live their healthiest and best lives. And other things you can do, so Help a Diabetic Child is one of the sponsors of this, this conference, which is just so excellent, and they have helped my patients so much. So they've provided free Libres, so free to use glucose monitors, and they're such a wonderful resource to really helping kids with diabetes. So if you can work with them, or I'm putting in a plug, I'm not affiliated with them, so I can say you can donate to them or do whatever. They're an excellent organization. And then other organizations, so T1D International, the American Diabetes Association, JDRF. There are a lot of organizations working on it, more affordable insulin and supplies for diabetes. So getting with those organizations and trying to help advocate for those things. So this is me with the ADA at one of their Hill Days. And I think that's it. So I don't know how far over time I went, but there's time for questions. All right.
Is there any quick question? Go ahead.
So during COVID, the most striking data to me actually has been type 2 diabetes in kids with COVID. Yeah. So I think, I'm trying to remember the study exactly. I believe it was a pound a month was what kids gained, and some kids, some high risk kids gained like a pound a month over COVID. And just, we've seen a lot of new onset type 2 diabetes cases, unfortunately, and some of them are presenting in the hospital, being really, really sick with ketones. Type 1 diabetes, there was some thought about COVID, attacking beta cells or causing autoimmunity, these sorts of things. I think that's still being kind of worked out, but mostly it doesn't look like it's really, other than, when you have an acute illness and you're on the verge of getting diabetes anyways, the illness can kind of push you over the edge in terms of your insulin function and all of that. So that might be part of it. But in terms of COVID causing autoimmunity or causing type 1 diabetes, we don't really think that that's the case.